Thank you. I'm going to be presenting this study on behalf of Lorna Jenkins and the entire team. Lorna, unfortunately, was not able to make it due to illness. Also, the mathematical modeling analysis here were conducted by Jamie Nordio. No conflict of interest to declare. So Panama adopted treatment as prevention in February of 2014 officially. It reinforced its commitment to implementing treatment as prevention and the UNAIDS 1990 targets in June 2015. Our collaboration started in 2013, and it involves the Ministry of Health of Panama, the British Columbia Center for Excellence in HIV and AIDS, and the URMAC Center at Simon Fraser University. The Ministry of Health of Panama also actively engages the Ministry of Finance, local stakeholders, civil society, and academia. Our study is regularly updated through the feedback from these participants. The HIV epidemic in Panama is one of the most severe ones in the Central American region. HIV prevalence is the second highest in Central America, and also Panama has a high mortality rate. The epidemic is concentrated mainly in men who have sex with men, the trans population, and female sex workers. The female sex worker population consists of two distinct groups. Registered female sex workers mainly come to Panama from other countries. They are involved in the sex trade associated with the canal and shipping activities. They are provided regular STI and HIV testing, and their work permit is revoked to practice adult entertainment if they are found positive. The non-registered female sex worker population is mainly local. It's an unregulated sex trade, and there's no regular STI/HIV testing provided for this group. So the long-term goals of this study is, or this collaboration, is to integrate mathematical modeling to inform operational implementation of treatment as prevention and as the 1990 targets as well in Panama for the three main groups. And the current goal of the project is to use the available data to develop a preliminary model. And today I'm going to be focusing on the female sex worker results. One other important goal of our project is to identify data gaps and to inform the data collection process conducted by the Ministry of Health of Panama. And today I'm going to give you some initial insights into the dynamics of expanding treatment as prevention based on this simple model. So the model is a compartmental HIV transmission model, one for the female sex worker populations and the other for the sexual partners. It includes a susceptible compartment, an acute infection compartment, a chronic infection compartment, and a treatment compartment. HIV transmission can occur only between the two groups, not within the groups. The model is informed from data provided by the Ministry of Health from their regular surveillance activities, as well as qualitative studies and epidemiological studies, including focus groups that they conduct. We also use data from the literature to estimate some of the parameters. We fitted the model to data on HIV prevalence and antiretroviral treatment coverage by calibrating infectivity and HAART initiation rate parameters. Some of the key assumptions of the model are that registered and non-registered female sex workers form a homogeneous group. We do know that this is an inaccurate assumption, and work is in progress to provide the project with more information on that assumption. We also assume that Panama's HIV epidemic has reached an equilibrium, and the reason for that is also related to data. We're currently in the process of acquiring data for multiple years to test this assumption. There is no treatment initiation in the acute phase of infection, and the chronic HIV phase includes latent infection and advanced HIV. We have simulated 2 treatment expansion scenarios. Both of them assume that treatment coverage in all populations is 47% at baseline. And the simulation scenarios begin in 2015 and continue for 15 years. And the target or the goal of the treatment expansion is to reduce HIV incidence in the female sex worker population by 50, 70, or 90%. And we compare those 3 options. And this target is specified for female sex workers because the sexual partner population is elusive, difficult to define, so public health interventions are much easier to target for female sex workers. The questions that we asked for this analysis were informed by practical questions that are of interest to the Ministry of Health in expanding treatment as prevention, and include the required HAART coverage to achieve the targets, the required costs, and the HIV incidence outcomes in 2030. We also try to estimate the time of entry into cost recovery period for this. The 2 scenarios that we considered are increasing treatment as prevention or treatment coverage both for female sex workers and for sexual partners. This is scenario 1. And in scenario 2, we just increased treatment coverage for female sex workers, but also looked at the outcomes for sexual partners. So looking at the 50% incidence reduction scenario for female sex workers in 15 years, we find that this can be achieved by both scenarios for female sex workers by increasing treatment coverage to 69% within the 15 years. If for sexual partners, for scenario 1, when we actually actively increase treatment coverage, it would require 81% treatment coverage to reduce incidence by 50%. However, even without increasing treatment coverage for sexual partners, by the interactions of the 2 populations, by the end of the 15 years, coverage would increase up to 60%. The same results for 90% incidence reduction scenario show that it would require 92 or 99% increase in coverage, or 92 or 99% coverage to achieve an 88% reduction in incidence for female sex workers. So we have not been able to achieve the 90% target, but it's close. And that same reduction would be 86% for sexual partners, and it would require 92% treatment coverage for scenario 1, and 73% would be the resulting treatment coverage for scenario 2. This busy slide summarizes the entire analysis for all 3 incidence reduction targets and both treatment expansion scenarios compared to the baseline. And I'll just draw your attention to the bolded lines, which show the cumulative number of new infections as well as the cumulative costs for each of these scenarios after the 15-year intervention period. And the most interesting result is that in scenario 2, focusing on female sex workers only for expansion of treatment as prevention, would be somewhat less expensive and would also result in a combined fewer number of new infections for the 2 populations. We also investigated and looked at the long-term impact of these interventions. In this case, we would assume that the 90% incidence reduction target for female sex workers was achieved and was increased to 2030. I apologize, that should be 2030, not 2020, and maintained for another 30 years. And so what we see is that even with just 15 years of intervention, incidence continues to decrease in the long term. And so how long does it take to begin recovering some of the investments in treatment? For scenario 1, it would take 40 years, and for scenario 2, female sex workers only, it would take 29 years. So what this means is that what we did here is we simply compared the cumulative costs for the intervention and compared it to the cumulative costs for the baseline, and just identified the year when the intervention costs begin to drop below the baseline costs. So these preliminary analyses indicate that treatment as prevention is feasible and effective for female sex workers in Panama. Also, it appears that focusing on the key populations, which would be more feasible from a public health perspective, is helpful. Through continued data collection, we will improve our model, and specifically, some of the next steps that we're focusing on is linking the female sex workers, men of sex with men, and trans populations, because there are known interactions between these. We will also include other treatment and care-related costs in an expanded cost analysis, and we are in the beginning stages of producing an operational health system model for the entire continuum of care of Panama. I would like to acknowledge the Ministry of Finance and local stakeholders in Panama, whose very high level of engagement in the project is making this possible, as well as support from the University of South Florida. And the study was funded by Canadian Institutes for Health Research Grant and other funding from Simon Fraser University. Thank you.